Most people have heard of morning sickness. It is considered a normal part of pregnancy, an uncomfortable, but expected, rite of passage. Somewhere between 70 and 80% of pregnant women experience some degree of nausea and vomiting during those early months. It can feel unpleasant, a bit like being carsick. But for most, it eventually passes. But for about 2% of pregnant women, the experience is something entirely different. This is hyperemesis gravidarum, often called HG, and it is far more serious than the term morning sickness suggests. Women with HG face relentless nausea and vomiting that simply does not stop. They cannot keep down food or water. The result is severe dehydration, dramatic weight loss, and dangerous malnourishment that threaten both mother and baby. The complications from untreated HG are genuinely frightening. Blood clots can form, blood pressure can spike to dangerous levels. Some women miscarry, others deliver prematurely in the most extreme cases. Hyperemesis gravidarum can even lead to maternal death. These are not rare hypothetical scenarios, they are real risks that pregnant women face when this condition goes unrecognized for far too long. HG has been misunderstood. Doctors, family members, and even pregnant women themselves have dismissed it as just a severe form of normal morning sickness. But it is not normal, it is a serious medical condition that demands proper intervention, including hospitalization when necessary to restore fluids and nutrients intravenously. The HER Foundation has been working to change this narrative, supporting more than 2.5 million people affected by HG and advocating for better recognition and treatment. Their work has helped countless women understand that what they are experiencing is real, it is serious, and they deserve medical care, not dismissal. For decades, doctors and researchers pointed to one hormone as the culprit behind pregnancy: nausea. Human chorionic gonadotropin, or HCG, was the prime suspect. It made sense on paper. HCG levels rise dramatically during early pregnancy, peaking right around the time morning sickness typically begins. The timing seemed too convenient to ignore. Textbooks taught this explanation, doctors repeated it to their patients, it became accepted wisdom, passed down without much question. But a groundbreaking study published in Nature in 2023 turned that assumption on its head. The research was led by Dr. Stephen O'Rahilly at the University of Cambridge, with Dr. Marlena Fedzio of the HER Foundation serving as first author, together with an international team spanning the United States, the United Kingdom, and Sri Lanka. They finally identified the true driver of pregnancy-related nausea. It was not HCG at all. The real culprit is a hormone called GDF-15. This discovery did not happen overnight. The team analyzed genetic data from thousands of women, comparing those who experienced severe nausea and vomiting with those who did not. What they found was striking: women with hyperemesis gravidarum had both higher levels of GDF-15 in their blood, and in many cases, a genetic predisposition that made them more sensitive to the hormone's effects. The evidence was overwhelming. GDF-15, produced largely by the fetus and placenta, floods the maternal bloodstream and triggers the brainstem's nausea response. HCG, despite its long-standing reputation, simply was not responsible. So where does this hormone actually come from? This is where the research gets really clever. Scientists used a technique called mass spectrometry to track GDF-15 back to its source. They were looking for a naturally labeled variant of the hormone. essentially a molecular signature that would reveal its origin. What they found was striking: the vast majority of GDF15 floating in a pregnant woman's blood does not come from her own body, it comes from the fetus and the placenta. This is a crucial distinction. The developing pregnancy is essentially manufacturing this hormone and delivering it straight into the mother's circulation during pregnancy. Placental tissues produce GDF15 in abundance. We are talking about a sudden dramatic surge that floods the maternal bloodstream. GDF15 acts on the brainstem, specifically targeting receptors that control nausea and appetite suppression. When those receptors get hit hard, the result is that characteristic queasiness and food aversion. But here is the puzzle: this same surge happens in pregnant women everywhere, yet the effects vary wildly. Some women are absolutely flattened by it. Others breeze through pregnancy with barely a twinge. The hormone levels might be similar, but the response is anything but that. Variation in sensitivity turns out to be the key to understanding why morning sickness hits some women so much harder than others. Not every woman responds the same way to rising GDF15 levels during pregnancy, and genetics plays a crucial role in determining who suffers most. Researchers identified 3 independent genetic variants in the GDF15 gene that strongly increase the risk of developing hyperemesis gravidarum. These are not subtle effects. The variants have a significant impact on how a woman's body handles this hormone. Here is where the story gets really interesting. Women who carry these predisposing genetic variants actually have unusually low levels of GDF15. When they are not pregnant, their bodies operate on a different baseline. This means they have very little exposure to the hormone under normal circumstances, so when pregnancy hits and GDF15 levels surge dramatically from the placenta, their systems are caught completely off guard. They are hypersensitive to something they have never really had to deal with before. It is like someone who has never experienced caffeine suddenly drinking 5 espressos in a row. But there is another layer to this: the fetus itself carries genes, and sometimes those genes differ from the mother's. Researchers discovered that when a fetus carries genetic mutations that the mother does not have, it can affect how her body responds. The fetus might be producing GDF15 at different levels than expected, or in different forms based on its own genetic makeup. This explains something that has puzzled doctors for decades. A woman might experience severe morning sickness in one pregnancy, but sail through the next one with barely a queasy moment. The genetic profile of each fetus is different. Each pregnancy brings a unique combination of maternal and fetal genetics, and that combination determines whether those early months feel manageable or absolutely debilitating. Here is something that genuinely surprised researchers: women with beta thalassemia, an inherited blood disorder, report very little nausea and vomiting during pregnancy. That finding seems backwards at first. Beta thalassemia causes chronically high levels of GDF15 in the bloodstream. If GDF15 causes morning sickness, these women should suffer more, not less, but the opposite turned out to be true. The explanation lies in how the body responds to sustained exposure. The researchers turned to mouse studies to understand what was happening when they pre-treated mice with low doses of GDF15 before giving them a larger dose. The animals showed a diminished response. They had essentially become desensitized. Their bodies had already adapted to the hormone's presence. This created a fascinating picture. Women who start pregnancy with already elevated GDF15 levels, like those with beta thalassemia, have systems that have learned to tolerate the hormone. their brainstem receptors have been bombarded for years, and they no longer overreact when pregnancy sends levels even higher. But women with low pre-pregnancy GDF-1/5 levels face a sudden shock when the placenta begins pumping out the hormone. Their unprepared bodies react dramatically. This bidirectional response opened an entirely new way of thinking about treatment. If prior exposure can desensitize someone to GDF-1/5, then perhaps doctors could intentionally expose at-risk women to small amounts of the hormone before pregnancy. The goal would be to prepare their systems in advance, essentially training the body to handle the surge that comes with pregnancy. It is an elegant solution that works with the body's natural adaptation mechanisms rather than against them. The discovery of GDF-1/5's role opens up some genuinely exciting treatment possibilities. What makes this particularly promising is that pharmaceutical companies have already been working on drugs targeting this exact pathway. But for completely different reasons. Cancer patients often suffer from a devastating condition called cachexia, which causes severe weight loss and muscle wasting along with relentless nausea from chemotherapy. Several drugs designed to block GDF-1/5 or its receptors are already in clinical trials for these patients. The infrastructure exists, the safety testing is underway, and the mechanism is understood. Now, there is a compelling case to test these same drugs in women with hyperemesis gravidarum. The desensitization research points toward another fascinating approach. What if women who are sensitive to GDF-1/5 could be gradually exposed to low doses of the hormone before they become pregnant? The idea would be to essentially train their bodies to tolerate higher levels, so when pregnancy sends GDF-1/5 soaring, the system does not go into shock. This pre-pregnancy priming strategy could be transformative for women who have suffered through HG before, and the safety data is encouraging. Researchers found healthy mother-child pairs where both carry genetic mutations that lower GDF-1/5 levels. These women and their babies are fine, which suggests that reducing this hormone during pregnancy is not harmful to development for women who have endured hyperemesis gravidarum. The prospect of recurrence is terrifying. The risk can be as high as 80% in subsequent pregnancies, but these developments from repurposed cancer drugs to pre-pregnancy priming finally offer something that has been missing for so long: hope for prevention.